What's up, y'all? Welcome back to In the Wild. I am your host, Ray Sean, and today we are exploring all things MCG, and we have a very special guest. He is the director for MCG's Center of Telehealth. So give a warm general welcome to Dr. Matt Lyon.
Thanks
for being here.
Appreciate you having me on.
So diving right in, can you share your experiences and insights into telehealth and how it has evolved overall for the state of Georgia?
Well, telehealth is a very important mechanism for healthcare delivery, particularly in Georgia and as large as our state is. MCG has been one of the leaders in telehealth. It's been around for a very long time, but the pandemic has demonstrated that telehealth is a viable means of delivering healthcare, particularly in rural communities where there may not be a doctor. The pandemic had a lot of bad things, but one of the things that it did is it exposed not only doctors to telehealth as a mechanism of delivery of healthcare, but to patients and also to the government. And so having all of us understand the power of telehealth is really big for us going forward. The part that I'm most interested in is rural communities. Many rural communities across Georgia don't have access to specialists. Some don't even have access to a local doctor. And so by being able to deliver healthcare through technology, we're able to reach those populations and decrease some of the disparities in healthcare. Because these populations don't have a lot of healthcare resources, they have worse outcomes of care. And Georgia's pretty low on the list of healthcare outcomes. So I am really excited about this as being a focus for our university and our medical schools so that we can reach these disparate populations and demonstrate that we can provide access to care across our state.
Yeah, because it made me also think of my own experiences growing up because I grew up in an area that we didn't have a local doctor. We had a local clinic, but it was very difficult to try to convince my mom to let us go to the doctor because she knew that we didn't have that same relationship with a lot of healthcare professionals that, people from a more populated community would have. So can you share any insights into how you train medical students on telehealth and how it might affect their attitudes and perceptions toward practicing in rural areas and engaging those type of communities?
It's a great question. There's a couple of parts to that. First off, it's really easy to think of telemedicine in particular as like FaceTime. And, a lot of times when we were in the pandemic, people were just using whatever they could. And so, they're using FaceTime or DoxyMe, and they were talking to patients. But that's not really what telemedicine is. I mean, to be effective in telemedicine, you have to understand not only the regulations, but how to use the technology effectively to get the information you need so that they get the same health care that they would have gotten if they were in your presence, if they were face to face. And so that is something that you do have to learn. There's plenty of people that understand how to practice in a live setting that may or may not want to go back and learn that. But what we're trying to do is we're trying to instill that ability to work through technology to reach people with our medical students now. And all of our students get training in telehealth. We're a little covert in how we do it. We don't actually tell them it's something different. We tell them it's the practice of medicine. And so what they do is they start practicing telehealth from very early on in medical school. So when they get out, it's going to be the same for them practicing live or practicing with technology. And so I really think that we're just at the very cusp of what telemedicine is going to do and how we're going to make things better in the future.
How can having telehealth training equip medical students more so to address those disparities that we experience in those rural areas?
Well, a lot of times the reason why there's disparities, is not as many people that live in rural Georgia, or they're more spread out, they're not concentrated. And so if you were a physician, you're getting out of medical school, you have loans, you want to pay back, you can see how it's a bit difficult to practice in an area like that just because you got to raise your family too. But beyond that, you also have the sense that you won't have as many resources to help you manage those patients, and you'll be kind of like a person out there by yourself, a single person on an island, I like to say. And so with telehealth, it's about connectivity. It's connectivity to the patient, but it's also connectivity from provider to provider so that you don't feel like you're just one person on an island, that you do have access to the resources you need to make sure you're giving good care. And so for me, the way I see it is that our students are learning telehealth from day one. They understand the connectivity, and so it makes it more likely that they will go work in a more rural area where there's less physical resources, but they're still connected. And so particularly with our Peach State scholars that we know are going to go work in rural Georgia, it's really important for me to give them the experience so that they see that they're not going to be alone. No matter where they go in the state, they can have connectivity, they can be close to the resources they need.
What do you think are some of the unique benefits and opportunities that telehealth offers with, like, say, emergency medicine, especially in those rural settings?
Well, emergency medicine is a challenging one. I have to be honest. If you're coming to the emergency department, it's often a time-critical illness, meaning that you want to treat something as fast as you can, and sometimes that, or a lot of times that involves an intervention. Doing something with the patient. So it's a little more difficult. I can't touch anybody with telehealth. But where it comes into being really important in emergency medicine is helping sorting people. So do they need to drive an hour and a half to come to a high-level specialty, maybe at our hospital, or can they just drive 20 minutes to the next closest ER and they can handle it because it doesn't require that intensity. And so a lot of times it's sorting, but in reality what it is that it's helping get people used to going back to their local ER. That if they know that they're going to be treated the same in their local ER as they would in an academic tertiary medical center, I think that means a lot to patients, that they know that they're getting the best advice. I'm not taking anything away from that local practitioner. What I'm saying is it's an augment. It's bringing more to the table. It's giving the patient more. It's supporting that rural physician. So these are never negatives. These are all additive. Really, they're more like multiplication. They're exponential. And so I think that if we can get people to seek care in their local community, and then still have the expertise like they had driven to a city, they're going to have better outcomes because you're decreasing the time from diagnosis to treatment because they're not driving unnecessarily. But you're also keeping those rural hospitals open because they have more and more volume. And then those practitioners have more and more complex patients, so they keep their skills up. So it's what I call the win-win-win. It's a benefit for the patient, it's a benefit for the rural hospital, it's a benefit for us because we don't have a lot of extra people in our ER that are slowing us down. We have the right resources for the number of people that we are seeing.
That makes perfect sense. Can you discuss any successful case studies or examples of how a telehealth initiative just positively impacted?
Absolutely, yeah. So again, it's that win-win-win. There's individual patient stories of how you make that critical diagnosis in that rural hospital so they don't have a delay in treating that. But the one I like to talk about is Candler County Hospital, which is in Metter, Georgia. Back in 2018, before the pandemic, when the state was listing out their most vulnerable hospitals for closure, Candler County was number 2 on the list, so it was at very high risk of closure. Why that's important is that what we find is if a rural hospital closes, not only does the health care of that community get worse, but the health care of the community around that county actually gets worse too. So it's really important to have these rural hospitals be able to stay open, but also take care of sick patients. So with Candler County Hospital, not only were they at risk of closing, they were transferring a lot of people to out of their rural hospital to regional centers. And what that led to was a decrease in skills by their nurses, their respiratory therapists, their clinicians. They just weren't capable, they weren't comfortable of taking care of higher complexity patients over time. It's just a negative cycle. So not only did we bring in telemedicine before and during the pandemic to Candler County Hospital, they also brought in some more physicians that really wanted to use telemedicine to improve the complexity of care there. And what we saw is that they went from an average daily census, that's how many people are in their hospital, of about 4 patients. and now they're running maximum capacity. They're running about 22 patients a
Oh,
day.
wow.
So it's a massive increase, and you can think about that. That is, if that brings in a lot more money. So they've gone from being in the red and losing money month over month to now making money, so that they have a positive cash balance, so that they are not vulnerable for closing, at least right now. The other thing that you saw is that they're what it's called the case mix index, but it's like the complexity of care of those patients. It's increased from 1, which is really low, to 1.5. That's a massive increase. And so they are taking care of much more complex patients than they were before they started this program. So not only do they keep them more, they're providing more complex care, and their physicians, their nurses, their respiratory therapists, the pharmacists, they feel more comfortable taking care, more complex care, so they're keeping even more people. And so it's a positive cycle. We talk about the win-win-win again, it's benefiting the patient, but it's really benefiting that rural hospital and the practitioners there, and keeping their skills up, and then they're not so apt to leave and go to a big hospital themselves. They can have great patient care, they can have a great career in a rural hospital, and yet still feel connected to the community as a whole.
What is that experience like for you to see with just that hospital in particular of like, hey, we're able to help them really like maintain and still be of service to the community?
It's been something that I've wanted to do for a long time. Rural, urban healthcare disparity is something that I've been very interested in for a very long time. But there's not a lot of great ways to solve it. I've tried a lot of ways, and this is the first one where I've seen really strong change in that disparity, because you can actually see the outcomes. You can see these changes over time, and it's really important for me. And now what I'm getting to do is I'm going to those rural hospitals and I'm saying, look, you're an excellent hospital. You've really increased what your abilities are. You have a lot to offer. Why don't we start training medical students, residents in your hospital? Because not only will they get great training because you're taking care of more and more complex patients, that's a great training environment. It's also smaller, so you get to know everybody. It's even a better training environment in some ways. But also, they may want to work in rural Georgia now. So when they see all of this working together, they see that ecosystem of connectivity, a strong community, buy-in to programs, and also the community lifestyle of living in rural Georgia. It may be something they want to do. So to me, the real benefit is that we have more places to train our students and residents, which will have a long-term impact. I mean, it'll outlive my career, I think.
So as going off of that, as telehealth continues to evolve, what do you think the ongoing support and resources should look like for residents, medical students that med school should provide?
Well, that's a tough question. I'll see if I can give a coherent answer. The MCG is very supportive of this program. I mean, starting with family medicine, we've had a very diverse training environment through rural Georgia, with a lot of our former graduates and then other clinicians in practice working with our students. A little bit of a difference here is instead of MCG working with an individual physician, it's MCG working with a hospital. And so it brings in all the physicians and all the practitioners of that hospital that are part of that learning environment. There's nothing wrong with either system. It's just a little different. In the past it was, you would go to a family medicine practitioner's office, and you would get great experience. But here you can go to the hospital and work with the hospital paid physicians, employees of the hospital. You can go to their outpatient, you can go to the FQHC, you come to the inpatient side, you can work in the emergency department. If they have an OB, you can see the OB and delivering babies. So it's more of a comprehensive program. So, MCG is fully supportive. I don't think there's a lot of resources that need to be added in. Working with AHEC, we've been working on getting housing for students in these rural communities, which can be a challenge. And so really it's just something that will develop over the future, but it's really more of a focus on the hospital community aspect of care, more so than just the individual practitioner.
And last question, what advice would you give to future med students or those who are not not thinking about rural healthcare before this conversation, but now maybe considering it?
Well, I think that there's a lot of people that come to MCG that are from, Dr. Hess will call it the Ettas, Marietta and Alpharetta, but they come from larger cities. That's just normal. That's where population centers are. But when you start seeing the lifestyle benefits of living in a smaller community, and also you can have a fantastic practice, I think that it's important for all of us to be able to demonstrate that to students so that they see what we call the other Georgia, that Georgia that's outside of major cities. It's really a life mission of mine. And so I always like talking to students and residents about how they can expand, their opportunities by looking outside of cities. And so with this program and telehealth in particular, providing the connectivity, it does make it a more viable option for more people.
Well, thank you, Dr. Lyon, for being here, and I'm sure everyone listening will look into telehealth a lot more.
Thank you so much.
The Masters Marathon.
Yes, sir! Welcome to the Masters.
I'm Linda Lee, and I'm a cashier.
I'm Carson. I'm a headwear floor stocker.
My name is Sana Nassar, and I'm a cashier. I go to Augusta University, and this is our spring break, actually. We really enjoy spending our spring break here.
I love it.
I love interacting with the customers. I like seeing where they're from.
It's really a lot of fun, and the time goes by really fast.
I can get you right done here.
All right. Enjoy your Masters, sir. Thank you.
I go to school at Augusta University. It's been a great experience just being here, seeing the course, just getting out here. So we work as usually a team here back here, and we'll pass each other the hats and we'll put them in the inventory.
That's going to be 648. You're all set. Have a good one. The best part of the job is honestly meeting people from around the world. Just yesterday I met people from Canada, Tokyo, England, all around.
Hello. How are you doing? Good. I am the cashier, so I'm in charge of ringing up, doing the receipt, and scanning.
And I bag the items, and I make sure nothing breaks, and then at the end I hand them their bags.
Right, your receipt's in the bag, ma'am.
Thank you very much.
Enjoy your Masters.
I felt so welcome coming in. My supervisor was so nice and guiding me.
I mean, everybody's just happy to be here. Everybody's just got a huge smile on their face because they know it's such a special place to be.
I would definitely apply. Doing this firsthand and experiencing yourself, it's like no other experience that you'll have.
Go Jags.
Go Jags.
Go Jags!
Welcome back, y'all, to In the Wild, and joining me to continue our conversation about the Medical College of Georgia is a very, very special guest. He is the Dean of the Medical College. So give a warm drum of welcome to Dr. David Hess. How's it going?
Good. Very well.
Thanks for being here. And getting started, just diving right in, because we're talking about how MCG is expanding and how it is essentially Georgia is MCG's campus. And recently it was announced that we're moving to have a 4-year campus in the Savannah area. So could you share a little about the vision and motivation behind the expansion to Savannah?
Yeah, well, first of all, we have a major doctor shortage in the country and then one in Georgia. So Georgia ranks about 40th per capita in the country in physicians per capita.
Oh, wow.
And there's many counties without any doctors. Half the counties don't have obstetricians, gynecologists. And we rank 49th in the country in maternal mortality. So that's not all because of lack of physicians, but it's certainly a contributing factor. So MCG, we're about the 9th largest medical school in the country, certainly in the top 10. We have an entering class of 264 students. Today I just did orientation for our class that just started today. We start earlier. We have a brand new curriculum we call 3+. So you can graduate from medical school in 3 years instead of the customary 4 years. But if you do that, you got to do your residency. That's extra training after medical school in Georgia. And then you got to agree to practice in underserved Georgia. Now, most of Georgia is underserved. We have regional campuses all throughout the state. We say Georgia's our campus. It's true. We have about 350 teaching sites, and we have regional campuses in Albany, southwest Georgia, northwest in Rome and Dalton. We have a partnership campus in Athens, which is 4-year, which presently has 60 students. And then we have a clinical campus in Savannah and Brunswick, but we're about to start another 4-year campus in Savannah. That's the big news, and we hope to start next July at this time. We'll then have 40 students to 264, which gives us 304 students per class, which will probably rank in the top 3 or 4 or 5 largest medical schools in the country. So Georgia is a big state geographically. It's very heterogeneous. We got the mountains, kind of Appalachian in the northwest, then we have the cotton fields and the peanut fields in the southwest, then we have Savannah and Brunswick, the kind of the coastal campus, and we have Athens. But the reason we're expanding to Savannah is, well, number one, the students love it there, and we have a very well-established clinical campus there. So we already send 3rd and 4th year students there to St. Joe's Candler. That's a big health system there, and they've been very supportive. The CEO there, Paul Hinchy, as a personal friend, has been very friendly to MCG. And then it just so happens across the street, this is geographic, perfection, across the street from St. Joseph's Hospital is the Armstrong campus of Georgia Southern University. So when we do these partnership campuses, we partner with another University System of Georgia school. So in Athens, it's University of Georgia. In Savannah, it'll be Georgia Southern, specifically the Armstrong campus. So the Armstrong campus had a little extra space, and we went down and looked at it, and the Board of Regents provided about $1.7 million or so to renovate that, to provide it as a medical campus, as the beginning of the medical campus. It's actually very economical to do this because they have excellent facilities. We've got to work a little bit on the anatomy lab. We had to redo some of the classrooms and offices. But location-wise, it couldn't be better. It's literally across the street where our 3rd and 4th year students are. They're also at Candler Hospital, which is, 15-minute drive up towards Savannah. So that's exciting. And I just got off a call here about preparing the IT and the classroom services to do that campus. Because one nice thing about our curriculum is it's compressed into 3 years. And people think, well, boy, can you really get to medical school in 3 years? Is that medical school light? Somebody asked me. Certainly not, because there's more credit hours in 3 years than there used to be in 4 years. And then the 4th year, most students will stay and they may get a combined degree. They'll do research. They'll do continued training. So only a few will probably graduate. Of 264 students last year, only 5 graduated in 3 years. But we expect that number to expand to maybe 30 or 40, over the coming years. So we have a large medical school. We have an old medical school. It goes back to 1828, 13th oldest in the country. And we have a very innovative school, allowing students to finish in 3 years, allowing them to really go anywhere they want in the state and train. So it's exciting.
And what is that like, I guess, for you to see this growth to becoming maybe in the top 5 largest schools in the nation, being able to really spread across the entire state? What is that like for you as a dean?
Well, it's exciting. The whole, it's a team. It's basically a team approach, and it's all we. We really have a great team that wants to do this. And what's exciting for me, being from New Jersey outside of New York, is to go around Georgia. Last week I was in Albany and Thomasville. Thomasville is down by the Florida border, and trying to develop out that campus there, and talking to physicians throughout that area and trying to expand even the number of students that are down there, particularly in Thomasville and Albany. So it's a lot of fun. But it's driven by the great need. It's just we're really behind in getting enough doctors. So we need more medical school slots, but we also need more residency slots. So after, when someone goes to medical school and they spend 3 or 4 years, then they have to do a residency. training, which is anywhere from 3 to 7 years, depending upon what they're doing. So it's a long haul, but you've got to have those graduate medical education spots after you graduate from medical school for your residency. So one of the things we're working on is trying to work with hospitals to develop those slots so our students stay in Georgia, right? You know, if they just go to medical school and they do their residency in, New York City or something, God forbid they could stay up there. Just kidding. But we're here to produce doctors for Georgia. 95% of our students are Georgia residents. So we really have a Georgia focus.
That's awesome. And how do you foresee, I guess, the new four-year campus in Savannah really just enhancing the educational opportunities for our med students and residents in terms of training, research, but also like community engagement?
Yeah, well, that's a very good point. First of all, there's data to show from other medical schools nationally that if you train in a regional campus, you're more likely to practice around that regional campus. So just by having the students in Savannah, they're more likely to stay in Southeast Georgia. Because we've had a presence in Savannah, third and fourth year, for well over 10 years, for 15 years, we already have a lot of community engagement. We already have a community advisory board that's advised us about this campus. We're actually meeting in early August. We already do some community research down there. There was a nice presentation by almost all of our students did research projects just this past year. So that's going on. Some of them did it with Georgia Southern faculty. Most of them did it with our faculty. So we're already quite engaged in the community. There's a number of clinics, indigent care clinics that St. Joseph's Hospital run that our students already train in. So we're very engaged in the community and in Brunswick too. One of the things about these regional campuses, be it Rome or Dalton or Brunswick or Savannah, the community is always supportive of them. And we do a lot of volunteer work in the communities, and the communities then turn around and support us. For example, a lot of these health systems or communities support us with housing, or our AHEC, which is based here at Augusta University, and MCG helps us. Those are the area health community organizations, the AHECs. And so they help us a lot with housing. So it really is, it's a team approach, it's a state approach. And then lastly, I've got to thank, the legislature. The Speaker of the House, John Burns, was very supportive. Butch Parrish, who's been very supportive to us. And then Sonny Perdue, who's our chancellor and the Board of Regents, made this happen. We came up with the idea kind of with them, and we thought this was a good idea, and we went down and toured it with them. And then I want to thank Georgia Southern, the president there, our president here, to make it work. Dr. Keel was very supportive. The president down there was Kyle Marrero. He was very supportive. So, everybody came together to make this work.
I'm sure that's a great feeling, seeing how really the entire state is coming together to support MCG. But besides going where the need is great, what other factors go into finding out or determining what location, I guess, MCG should look at next?
Yeah. So we try to put our regional campuses. Our first regional campus was actually in Albany. And Southwest Georgia has the most severe doctor shortage. The doctor shortage tends to be worse south of I-16. So while Savannah itself isn't short, the areas around Savannah are short. So all of South Georgia is particularly short of physicians. So we like to put our campuses where the doctor shortage is the most severe. Now sometimes that's difficult because you have to find these doctors to train them. A lot of these doctors really, they volunteer to train our students, really out of the goodness of their heart. And they also get a tax credit, thanks to Denise Cornegay and the legislature that allowed that to happen. So they get a tax credit from the state. But we usually look at that, and the second thing, getting back to what you were asking before, is how engaged is the community? We can only go to a community where the community wants us and is supportive of us. So all our communities, Rome and Dalton, Albany, Brunswick, Savannah, they're all very supportive, and Athens is very supportive of our partnership campus. So we enjoy great support. We expanded in Savannah because it became the largest clinical campus, and we had great support from our health system. And then it just so happened that Georgia Southern Armstrong campus was across the street, because the first part of medical school, it used to be 2 years. We call it the preclinical. So they're kind of learning from books, and they're learning anatomy. They learn from simulation models, but it tends to be a lot in the classrooms, mostly in small groups. That part we've narrowed down to 18 months, and we kind of need a university to do it, or a setting where there's classrooms, and so that's why the Armstrong campus worked out so well. So you kind of have the typical university classrooms on one side of the street, and then the other side of the street you have St. Joe's, then you have Candler Hospital, just 7-8 miles away. Don't quote me, I have to look at my map, my Google map of Savannah, but it's not far. And then when we're in Savannah and Brunswick, we go to all the surrounding areas. So we put students in Statesboro, they're in Liberty County, they're in a lot of these counties surrounding Savannah and Brunswick. So when we go down, same thing when we go to Albany, we have students all over. We have students in Columbus, we have students in Tifton. They're all over that area. They're not just in Albany. That's why we call it the Southwest campus, the Southeast and the Northwest.
So what does that experience look like for med students? So like their first year, I guess they would be at one of the 4-year campuses, but then I guess as they matriculate, how do they get to a regional campus?
So good question. So when they come in, when they get admitted, they have to decide between Augusta and Athens right now. So 204 go to Augusta, 60 go to Athens. Next year, they'll have 3 choices. It'll be Savannah, Athens, and Augusta. So for the 4-year campus, you've got to choose when you're admitted. Shortly after you're admitted, you get to choose, and most people get their first choice. Now for the other campuses, the regional campuses we call them, they're 2-year campuses, right? They spend their clinical part there. So after the preclinical part, there's a lottery now, and we. After COVID, we went back to doing bus tours. So we do bus tours. We take them on a bus, show them Albany, show them Rome, show them Savannah or Brunswick, and that's how they choose. So sometimes word of mouth. Sometimes they're from that area. A number of students from Albany like to go to Albany, but then you have students from Augusta and Atlanta that choose Albany, or choose Rome or Dalton. So it depends. The advantage of the regional campus is that you don't have residents. Residents in some ways are very good to work with. But if you don't have residents, you deal directly with the faculty member. So you have a lot more hands-on experience. So you can deliver more babies, you can be more active in the surgical cases if you're at a regional campus. So the nice thing about our campus is we have all sorts of flavors and options. In fact, we have so many options. It's like going into a restaurant with a menu, and there's so many good things on the menu. What do you choose? So we have to have a lot of career advisors to kind of advise them, what they may want to go into and where you may want to go. So we've really beefed up our advising as to help the students make those decisions. But a lot of it you make by word of mouth, and some people like Savannah and like the coast. Other people like Albany and the challenges. All the campuses have their own culture. It's all a little different. It's hard to describe until you've been there. And all the deans are very competitive. So they like to, they all think they're Kirby Smarts. They're all trying to recruit the students to their campus. So
I'm sure that's a fun challenge. Another thing that I really admire about MCG is that we're one of the most diverse medical colleges in the country. How does that happen? Because I'm sure there's intention behind it, and it doesn't just happen by accident.
Yeah, we have a holistic admissions process. Now, medical school is tough. You have to have a certain grade point average and what we call an MCAT score. That's the medical college admission test. Because you don't have that, the data shows you'll never pass all the tests you have to become a doctor, right? So you have to have some basic, proficiency in taking tests, and you have to have a pretty good grade point average because they do predict. But beyond that, we do a holistic process. We do multiple interviews where you have, up 6 to 8 interviews, and you go to different stations. You're interviewing on professionalism, things like this, emotional intelligence, things we're trying to look for. And so it's a holistic process. So that's how we get a diverse class. Yeah, if you took a picture of our class, just look at a picture of our class, you'll see how diverse it is, just how people look, right? But they're also from all over the state. So we give preferential weight to people who are from underserved Georgia. And we don't get as many applications as we would like from Southwest Georgia. So now we're working on, we've always had pipeline programs. We've had something called the SEEP program. The SEEP program has been going on for more than 50 years. It's one of the longest running pipeline programs. It's generally been geared to underrepresented minorities and underserved populations, mostly in Augusta, but it's also in Savannah. It can be as a high school track and a college track. So we try to get students interested in medicine early. Now, some of them may not go into medicine, they may go into nursing, but we consider it a win as long as they go into a health profession. So we want to do more and more of these pipeline programs at the different universities throughout the state to try to keep, a diverse population, diverse student body that looks more like our state. Most of the population is in Georgia, right? 60%, and that's about 60% of our students come from there. But you wouldn't really expect it to be any different. It's just where the population is. But it's hard to get the population to practice and physicians to practice down in South Georgia. I mean, every medical school faces this problem. It's hard to get doctors to go to rural areas because they have to worry about schools, their spouse, their kids. It's complicated.
Switching gears a little bit, as dean, what would you say would be your vision for the future of MCG, including the regional campuses, four-year campuses, MCG overall? What would be some other things you would like to see?
Well, we want to be known as the innovative medical school. We've always been strong in teaching. I think it's a great teaching medical school. I think when our students go to residencies, they're appreciated. We get feedback that they're almost always the best prepared students in their residencies because they get early training. We'd really like to go into more digital health and telemedicine. Matt Lyon, who I think you talked to earlier, is our director of the MCG Center for Telehealth. One of the issues is if you have a state where people are spread out in rural areas, you can deliver a lot of care by telemedicine, by two-way communication, audio-video communication, and digital health. So we really want to expand that. You can't do everything remotely. You gotta touch people and you gotta see them. You gotta have boots on the ground, but you can do a lot of follow-up that way. And we train our students. Matt Lyon and his team train our students in the first few months of medical school to do telehealth consultations, right? So that's a big part of it. So very strong in digital health, education. We really want to be statewide, and we want to be innovative. We really want to be innovative in how we educate students. If we can get them out in 3 years, great. All right, but if we, some of them are going to stay longer, what can we teach them in that extra time? I said digital health is important, telemedicine. It's really socioeconomic determinants of health, are very, very important. Because what really determines your health is not necessarily that you have a lot of doctors, it's your zip code where you live. So what I'm fond of saying is zip code is more important than genetic code.
Oh, wow.
So it's very, very important. You look at zip codes, and that really determines how long people live. And a lot of times it's poverty. Sometimes it's pollution in the area. Not so much an issue in most of Georgia, but it can be in some parts of the country. But it's lack of education, et cetera. And then it's health behaviors, bad health behaviors that people get into. And they're very, very hard to get out of. So we have to work on that. So we really want to work on rural health. And we're trying to get a large NIH grant called a Clinical Translational Science Award. And our whole focus on there is health disparities throughout the state of Georgia. And it's Georgia-wide. And we're really focused on the areas outside of Atlanta in that. So we really want to be statewide. Producing more physicians is important, but health is a lot more than health care. Health care is what doctors and nurses do, but health is much broader than that. And to affect health, it's more complicated, and it requires a lot more outreach. It requires a lot of health policy changes, right? It really does, because if you have poverty and lack of education, it's going to really be hard to improve the health of people, right? And unfortunately, medicine has never stressed in the United States like it should prevention. We tend to get to diseases late. We're very good in this country of diagnosing and treating diseases late. Like if you have a cancer that's, spreading throughout your body. We're very good at diagnosing that, knowing where it's going, and giving you the best treatment there is probably in the world for that. But we're not good is preventing the cancer from starting to begin with, not, inculcating health behaviors that prevent that from happening. We're not really good statewide at treating high blood pressure, which is probably, the most preventable risk factor for stroke, heart disease, and you name it, right? If we could treat hypertension, that would have a huge impact on the population of Georgia. So we really want to look at that. We really want to see how we can do that. And a lot of that is getting into people's homes, right? And not necessarily making them drive to Augusta for an appointment. I mean, they may have to drive to Augusta now and then. But the more we can do that remotely, and as you know, everybody has, even I have an Apple Watch, right? We can now track people's steps. We can soon track people's blood pressure, heart rate. There's a lot you can do with wearable devices, and that we can do a lot more remotely than we used to. So we really have to start doing better at prevention. The trouble with prevention, the reason more doctors don't do it, it's just simple. It's not reimbursed. It's not reimbursed very well. So we have to change the reimbursement schemes, and that's a tall order. I wish I could snap my finger and do it, but that's very, very difficult to do. But it's a process that has to happen, right? And right now, the state of Georgia, there's more and more interest in health. There's a big, health committee now that Butch Parrish is running, and it's often the state has to look at workforce, and we're looking at that. It's not just doctors. We need more nurses. We need more other healthcare professionals. But we also have to think really how do we focus on prevention and focus on things that not only pay doctors well, but really pay off in patients, right?
That's very true. Switching gears a little bit, thinking of all of the innovations that you talked about for the Medical College of Georgia, and reflecting on your own medical school journey, is there anything in particular where you're like, man, I wish I would have been able to study this when I was a med student?
I would say immunology. We started a new center for immunology, and immunology is completely different than when I went to medical school, what I learned. It's pretty much all the immunology books have been rewritten. So that's on a kind of a basic science level. I wish I had learned more immunology, but that's, what could we do? We just hire good immunologists to then teach us and teach our students the right way. I think, when I was in medical school, there really wasn't digital health yet. We didn't have the tools, but now that's exciting. I think what Matt Lyon and Center for Telehealth are doing, and our students come to that naturally. They're just natural at it because they grow up with it. As you get older, like I am, it takes a little bit harder and longer to catch on, right?
And last question, for all of our future med students who are looking forward to one day attending MCG, what would be your biggest piece of advice to them right now?
Persevere, never give up. I mean, sometimes you don't get in your first time. We've had some great examples of students get in the first or second time or third time, and then they became the resident of the year after they got in. So, persevere is the most important thing in life, right? Don't give up and just be determined to do it, and you'll succeed. Also, get some advice along the way about the course of study you should take, because you don't want to be going, you want to make sure you go to the right college, you follow the right curriculum. But really, perseverance is important. And, for a doctor, it's not, we focus on grades, but I said our admissions process is holistic. And we take other things into account. But some of the best students are the students that don't get in the first time.
Well, thank you, Dr. Hess, for being here and for all the work that you continue to do for MCG.
Thank you for having me. I really appreciate it.